plans. 63 to 64 states on Friday submitted their vaccine distribution plans. The other one just asked for a short extension. That's all going extremely well now. It's going to be so critical for protecting those small.
And before I let you go, the president went to Michigan, started talking about lock-her-up chance on the governor of Michigan over her coronavirus restrictions. Let me ask you this: to browbeat local officials and what they're think about.
Chuck, I'm not going to get into politics. What I'm going to talk about is red state, blue state, open state, closed state, open country, closed country. We see these cases spreading. Why? Because we've been in this for many months. People are tired. I talked about this back in February and March, which is you get mitigation fatigue. You know, people get tired, but the steps to mitigate right now are simple. Please wash your hands, wash your distance, wear your face covers, and watch your distance. Stay on settings where you can't do those things. Please be mindful of indoor gatherings right now as it gets cold. Just keep your guard up, hang in there with us, because the days are perfect.
Mr. Secretary, message coming out of the president's mouth that they make a lot of public health officials a lot happier.
Well, Chuck, the president's been saying wear masks ever since the April reopening guidelines. I'm his secretary. I speak for him. I'm telling you, that's the message. That's what I'm asking you all to have. President, do those things to the American people.
Secretary Azar, I'm going to leave it there. I appreciate you coming out and sharing the perspective of the administration. And joining me now is the Democratic governor of Michigan, Construction Governor. Welcome back to Meet the Press. I want to start with the state of the virus in your state before we get to the politics around the virus. So first, give me an update. Where is your state? I know you're part of this huge fight that most of the country is in. You've had some of your restrictions wiped away by the Supreme Court. I know some of them are going to get implemented. But here you're rising and your power to mitigate this virus may be being eliminated. What are you doing?
That's right, Chuck. So we are seeing COVID cases rise in Michigan. That's what that epidemiologist told us all was going to happen as we got closer to the fall. But I'm concerned because, of course, the Supreme Court decision in my state has created a lot of confusion and has worked to undermine what we've done here. We crushed our COVID spike early on. Our economy rebounded. Top 10 rebounding economies in the nation. However, it's all at risk, and this partisan decision out of our Supreme Court makes it more precarious than ever, a situation that's already very dangerous.
What recourse do you have?
Hello, just checking to see how everyone's doing. Oh, where are you all going? Okay. All right. So you got to take everybody. Where is Ryan? I gotcha. Gotcha. Good for you. Oh, what a shock. Everybody had a good night? Good. You'll have to fill me in on how we do this. Oh. Okay. Okay. You'll go. Okay. Good for you. Good for you. Good for you. Okay, but it was perfect for last night. And did you talk to Matt? Because I don't even know how to call him at this point. Okay. Okay. All right. How's Shane doing, I guess, is the question. Why? Oh. Okay, good. He's stressed. All right, so as soon as I'm done with my thing this morning, we'll... Right. Or If he's had enough and he wants quiet time, we can take him here. That's fine. I'm not stopping him. I'm just saying if you can sense when sometimes he just is like, stay away. You know how he just is like, so I'm happy to come get him. Okay, so, right, that's fine. He knows. We talk about it. He knows he likes sometimes having that, so we can discuss later. I'll be done by like 11:30. I should be finished. All right. So enjoy Publix. Right. Oh, good. I think they'll have fun. So, all right, you go ahead. I'll talk to you after my thing. Okay, bye.
I do think that the person with the biggest megaphone bears a lot of responsibility here. It's true. This is a public health crisis. It should not be a partisan moment, and yet he has made it that way to deflect from his administration's inability to get their arms around it. People are dying. People are out of work. People are looking for help just putting food on the table. And there is no relief in sight. Our numbers keep getting worse. And that is the sad, hard truth of this moment, Chuck. We should have acted as though, but not a war with one another, a war with a virus.
Hey,
This virus doesn't
how's it going?
This virus is still a very real threat to all of us. And if we could all muster the American spirit and put our masks on and take care of ourselves,
I hear you.
we will all be better off.
Okay.
But I'm not leaving anything a chance. I am working incredibly hard to make sure that he does win. I'm working hard to make sure that
Okay.
we
Very good. How's it going?
Michigan, and so we're launching a corporate forum.
Okay.
Working hard to elect them because
Okay.
this is a moment where
Slept
we
okay?
Americans have to elect leaders that are going to look out for our health.
Okay, good. Good. That was the best thing.
Get us back to work and make America a leader fight against COVID.
Okay.
And then finally, last night.
Okay, good.
Targeted the president personally.
Of course.
A lot for a chance,
All
targeting
right.
him.
All right. I just talked to Dana. I have my Sunday morning night program, my breast cancer awareness program at 10 o'clock. Should be done by 11:30, and then I'm free. I said, if you need me, or I said, if Jack is needing some alone time from everyone, can take him here, whatever. We're available.
The president of the United States, 10 days after a plot to kidnap, put me on trial and execute me. 10 days
Right. Well, Dana already said that I guess they've been talking about it, and Jack wants to swim with the kids. I'm just giving you a heads up. Yeah.
inciting
Right.
this kind of
Yeah. That's all. I'm just, yeah. All right.
It's dangerous, not just for me.
Right. Perfect.
And trying to protect their fellow Americans. People of good
Okay,
will
good.
sides of the aisle
All right.
to step up and call
All right.
this
Thanks.
out and bring the heat down.
Okay.
This is the United States of America. We do not
What kind
tolerate
like the
actions
what kind of medicine?
and
It's hard to get. Mm, right. Right. Right.
Up next, President Trump insists on
Mm-hmm. Okay. Mm-hmm. Oh, jeez. Right. Oh, God. Oh, my God. Somebody maybe was videoing you. You'll appear on YouTube somewhere or Twitter. Right. I hear you. No, I do. Right. Oh my God. Ay, ay, ay. What? Oh, jeez. Oh. Oh, oh, oh. Right, right. Cor- Right. So you'll go today and get it. Okay. Right. All right. Lovely. All right. Well, I'll give you a buzz back when I'm done. And we'll see what's happening. All right, honey. All right. Bye. He was doing.
Text, I haven't heard back.
Yeah, his phone.
I sent Shane that.
Yeah, I don't know. He didn't answer mine either. I just called. But he picked up. So Shane was doing better. He slept, through the night things. But it was his. I just want to keep making sure nobody's on. He went he didn't go early enough to the regular pharmacies. He had to go to one of the ones that are open late, and went to the first one and, like I said, waited. And the pharmacist had a few, but not enough. And he said, if I fill this, then you won't be able to get more. You're better off going somewhere and getting your full prescription, blah, blah, blah. So he found a 24-hour one on Goldenrod and somewhere, and he waited online for like an hour. And people, he said, think about where I was in town. And he said, then like somebody had cut in line and everybody started screaming. It was like, I said, and he was trying to stay quiet.
When did they get back?
Well, this was already 9:00 at night.
When he got home?
No, when he realized he hadn't filled the prescription.
Okay.
So then he got, finally, after an hour of waiting online, they apparently didn't have it or whatever, but like he said, he just like completely lost it and yelling at the pharmacist and turned around to everyone, don't even bother waiting. You're never going to get your, he was like, after criticizing other people who were, he said it was, so he was fine without the Percocet, apparently. He said, I'll go get it today. Anyway, but Shane was feeling better. He said, depending on how he was doing later, he was going to tell Lander and Carrie maybe to come by, because they didn't do it yesterday.
Yeah.
So
you need anything, let me know. If you need me to entertain Jack today,
yeah.
that helps him.
Oh, somebody, all right, somebody's on. Let me go.
Not early.
No, for the people who are in it. Oh, the doctor's in. Hi, doctor.
Hey there. Hi.
How are you?
Good.
Thank you so much for agreeing
Oh,
to do this
great.
today. We appreciate it. I just want to make sure I'm pronouncing your
Welcome.
name correctly.
Yes, Mira Iyengar.
Iyengar. Okay, Iyengar. That's what I kind of thought. So I'm good. So are you on a computer or?
I'm on a
your-
computer.
What are you? You are. Okay, you had a little bit of delay, so I didn't know if,
Oh, oh no. Is it terrible?
it's just now it's better. When you first came on, it was definitely more of a delay. I think it's okay now. And once you're speaking, it won't matter really. So I think you'll be okay. It might be your internet. You're like a
Good,
little,
hopefully.
yeah. Hopefully it's
I'm in
fine.
Oh, great. I will cut out in the middle of my presentation. It's okay.
I'll be like this, hey. We had that happen. I brilliantly have two big programs this weekend. I had one Friday night and now today. So I just said to my son, I was like, okay, an hour and a half and I'm done. But we had, it was like a Shabbat from, it was actually a Pride Shabbat. It was really beautiful. And the rabbi that was doing it was playing a guitar and singing one of the hymns, and all of it, he just started fading out little by little till you couldn't hear him. And it's like the other person who was helping me, where in the chat, his sound is gone. I think his sound is gone. And then other people started, I can't hear him. I can't hear him. And finally, the other person who I work with, she was like, Rabbi, we can't hear you. And then he stopped. He was like, oh, and then, and he had all the sophisticated, he had the earphones and he was plugged in here. And finally, it happened a second time and he just took everything off. It was like, forget all the fancy stuff. And then he just started doing it the way we are. It was like, these things happen. We can't, it's technology, but we do the best we can.
You're
So
right. Especially
it's all good. So I'm hoping that somebody from my office agreed to come on to help me this morning, and I'm hoping she hasn't forgotten. I don't think she'd forget. She'll come on. So do you do a lot of these things, talking around and?
do a few of them, yeah.
Yeah, your sound, you see
It
again.
never gets easy though. I'm always nervous.
Your sound is still like it's not.
Coming out.
I think it's if maybe,
All right. I'm gonna try to log. It like my internet. Leave and try to come back on.
Yeah, I think it might be your internet connection.
Different.
You're now you're like you're freezing. So I think it's your internet, it could be your internet connection.
Okay.
We got time. Hi, Dr. Pernicone.
Hello.
How are you?
Okay, how about yourself?
Very well, thank you. Thank you for being
Good.
here. We're just waiting for everybody to arrive.
Okay, I don't know how to, let's see, maybe I could, I don't know how to turn on the camera. I am a dinosaur. I do not know how to use a computer.
Oh, gosh.
All right.
I'm going away from the computer for a moment to send a link to somebody. I will help you in 1 second.
All right.
Hope other people are not having. Okay, okay, on the bottom, are you on your computer?
Yes,
So look on the bottom, if you scroll around, there's there's a mute button and then there's a video next to it that looks like a
right.
video camera. If you click on
Yes.
that, it should start your video.
It doesn't
There
seem
you
to-
are. You're
Okay,
perfect. That's it. You're
all
on.
right.
We can see you. Good morning.
Good morning.
Let's get everybody else coming on. We've got everyone one by one coming up. Let me put my name. Hi, Emily.
Hi, good morning.
Good morning. Trying to get everyone situated. Make everybody Emily, you're going to be speaking, so I'm going to make you a co-host.
Perfect.
Dr. Pernicone, I'll make you a co-host. I think that Danielle, is that you there? You can come on, you know.
Better, hopefully.
I know how to, oh, if you can hear me, Danielle, I can do the Facebook. I've got it. Okay, so Dr. Langer, is that you, are you better now?
I hope so. We're gonna
Yes.
find out.
Yeah, I think you're better. Yep. We're just testing everybody to make sure we can hear them. Let's see what happened to Deborah was trying to get on and she was having problems. Let's make sure nobody else is trying to reach me. I think we're good. So we're going to do Facebook Live so we get more people who can watch during or after. And oh, here comes Deborah. I will just set that up shortly. Hi there. Good morning.
Good morning.
How are you?
I'm home.
You made it back okay?
Yeah, just this morning.
Oh gosh, Deborah flew in across the country.
But I'm here.
Good, good.
How is everyone?
Everybody seems good. We've got both doctors. We've got Emily. We're missing Brianna. I see Shifra is connecting. Checking everything.
I can't get my page to enlarge, so I'm so blind. I'm gonna be
Oh
like,
gosh.
it's okay.
How many people registered for the event?
We didn't have a huge amount, but I'm hoping more will come on Facebook. So I don't know if it was the Sunday morning or what, or people are just so worried, not worried as they should, about everything with COVID and everything going on. I don't know. We had last year when we were live, we had a lot of people that were on that came in, I should say. But we also gave them a free lunch. So I said to someone, maybe it was that people just really came for the free lunch. I don't know. It's so hard to figure out. You try to do things that you hope are going to really help people and be important. And I don't know.
A major factor, I believe, is just the okay, as mothers, wives, professionals, whatever we have to do, when we have a virtual meeting, they have no compunction whatsoever in saying, oh, I've got a question. Where's this? How do I do that? Okay. But for instance, I registered for the American College of Surgeons meeting, didn't go to one thing. Why?
Mm-hmm.
Because people don't respect you're going to a meeting unless you leave
Right.
to go to a meeting. And so it's a problem.
Yeah, that's true.
It's, and then people register. So I was telling Dr. Unger before that I did another program Friday night. We did a Pride Shabbat, and the city of Orlando was actually a co-host. So they got the word out too. We had over 100 people registered, which was amazing. Nobody could believe it. But then when it came to the actual event, 50 people showed up, which was still good. And we also did the, Facebook Live, which it was great, which we're going to do. So hi, Danielle. This is Danielle Works Federation also. She's here to help us, whatever we might need. I will, at like 5 to 10, I'll go ahead and get the Facebook Live set up so then I can just click on it. I did it Friday night. It worked. So I feel like I'm okay with that. What?
Ha.
Yeah, thanks. It's 2020. Who knows what's going to happen?
Exactly.
We had a big thing planned for our family yesterday. I have a lot of kids and grandkids here, and it was supposed to be pumpkin decorating and carving at one of my kids' homes. And that morning we get the emergency phone call. His husband was out in the back trimming. They have a ton of bamboo trees, and I guess he was doing something where he pulled whatever, it smacked him in the face. He got cut and it hit his eye. And my son had to rush him. First, they went to the quick place, whatever you call it, where you can, the urgent care. They sent him to the ER. Well, of course, it became a whole, we took, we got the grandson and we did everything at another child's house. But the point is, you just never know what's going to happen. Mm-hmm. So he had no serious, he did scratch his cornea. That was, and his, whatever the thing, the socket was inflamed or whatever, but he'll be okay. But the point is, if something is going to go wrong, it's gonna go wrong. So it's anyway, but I think, I don't know where Sarah. Shifra, can you see what's up with Sarah? I know you're there, Shifra, even though you're on mute.
Yes, I'm here. I'm gonna send her a text right now.
Okay, because I
The
think
reason I'm not on videos, I'm still getting myself together. I have a few more minutes, so.
no worries. And Danielle, if you can hear me, there you are. If you could share the resource page. No, when here's Sarah, I see her. And then what I was thinking, Danielle, as each speaker is speaking, if you could type into the chat to everyone their resource information. So as I think Dr. Iyengar goes first. So when she's talking, if you could just type in her information as she's talking, at least people will have it in the chat each time as everyone is out there, if that makes sense. And then I think at the end showing the resource page will be really important. And we're also going to put, I think when we're done, if you could post it on our Federation webpage, then everybody can have access to it also. Here's Randy.
Carol, are you going to be putting it on Facebook Live?
Yes, I'm going to go get that set up in a couple of minutes. I did, yeah, I did it Friday night. It was fine. It took me a couple of minutes. So yeah, I'll do it right before, because I'm just going to say a quick welcome and then turn it over to Deborah. So at worst, we may miss Deborah on it. If I don't, I'll try to do it beforehand.
Honey, if I
That should be fine.
print off.
It doesn't take that long. You were right. It's very simple.
Yeah. Great.
So, and I think we'll be good to go. Anybody have any questions or anything? Sarah, how's your friend in New York?
She's fine. You know, she's like a mild case, but she doesn't have like she felt bad because she doesn't have her stuff with her. She just said, like, I'm not going to be at my best, but I'll do my very best.
So will she sing? Is that what she does?
Yeah, she's going to sing, and she normally, like, you know, she's a musician and a songwriter. Usually she'd have like her guitar, she has like the right equipment, you know, but she said she'll do her very best. The person who, just to update everyone, the person who is leading us in the musical prayer has got stuck in New York with COVID. So she went to visit her in-laws, and her husband came down with COVID, and they are, you know, they're there until their symptoms go away and they can travel again. So,
oh God.
But thankfully they're, you know, she said it's pretty mild.
Oh gosh. Someone told me they're going to be late. Okay. No, it's crazy. And it's funny you said about the equipment. I was telling them earlier for Friday night for the Pride Shabbat, Dr. Rabbi K had all his fancy equipment because he does a lot of stuff on, you know, live on Zoom, and he had the earphones and plugged in and all this, and he just kept fading. It was like we kept losing him. Yeah. So finally, Yael was like, Rabbi, we can't hear you.
Yeah.
In the middle, and it was like, he was like, oh, and then someone else took over, and then when he came back, he had no more of the fancy equipment. He was just doing it the way we're doing it. So sometimes the fancy equipment isn't always the best.
Right. Okay.
So we'll see what happens. I thought, oh, Randy, why is Randy, are you on, or is that you? No, we're not letting people in yet. Danielle, was that you?
No, that was me. I did it by mistake.
Oh,
sorry.
It's all right. It's a friend of mine, so it's not so. Yeah, okay. We're just gonna wait and let till 10 to let people.
It's probably best to keep me away from computers. I'm not kidding you.
You don't want to kick her out, though.
Maybe you should kick me out.
Oh, absolutely not happening. Not happening at all. So we're trying to keep everybody, you know, 10, 15 minutes, that kind of timing. That way we'll move everything along and I
I'll be
think-
last. I'm gonna
Okay,
be very quick.
okay,
Carol,
yes.
I have a couple slides, so can you give me the ability to share my?
Yes, I gave everybody else, like you came on after, I apologize.
Sorry.
I forgot, no, it's fine. You're
Setting
done,
two
you're
kids
set,
up
you're
on-
a co-host. Hi, Jill, we weren't really supposed to have you come on yet, but it's okay since I know you. You can just hang, we're just discussing, nothing is gonna happen till 10. But hi, I haven't seen her, she's my very, very dear friend who's unfortunately her mom passed away a few weeks ago and she's been in Miami. Not that I saw her before. You're on mute. I can't give you, you can unmute yourself.
Hi.
Hi, hi.
Hi, long time no see, you're here.
So
All right, I'm gonna unmute I'm gonna
can.
mute myself and I'm gonna
go
go
away?
bye-bye. I'll see you in a
Okay.
little bit.
Okay,
Bye.
you got it. No worries. I hope we'll get more people coming in. I hope. Were you able to share it again, Sarah, like with a lot of people?
Yeah, I mean, I posted it everywhere, and
Okay.
I'm gonna share. Oh, you know what? I'll share the Zoom link now on WhatsApp.
Okay, perfect.
And Carol, so often with our Facebook Live events, so many people watch them recorded later when it's
Right.
convenient. So that's what we're finding at Komen.
Mm-hmm. And I looked, as I said, I did it Friday night on for Pride Shabbat, and yesterday there were already over 500 people had viewed it. So
Yeah,
I
I'm
think-
finding more people watch it on Facebook Live than on the Zooms. I mean,
right, which
you
is
know.
fine. So we'll do our thing, even if no one comes to play with us, and then it'll be out there for everyone to see and hope. Look, we just want people to get the information. I mean, that's the
Yeah.
important
And
thing.
and people on this, those of you that are here, you could share the Facebook Live that Carol's sharing on your own pages or your own group pages so that more people can have access. Like I plan on sharing it on my personal page and on my organizational page. So that way we, just more people get to see it.
I'm gonna start to get it ready now. Where do you want to post this? Share on page, you manage. So glad I learned how to do this.
That's impressive.
I think so.
Are you doing this?
I'm doing this now. But I think it can prep. It doesn't last, but it should hold on for like 10 minutes. It should be okay. And then I just click go live. And Sarah, do you know how long it stays pre?
I think that you have to do it within 5 minutes. I
Oh,
was
5.
like, yeah, something like that. I remember I one time did it too
Mm.
far in advance and then I had to restart. So,
Okay. Yeah, because now it's set. So
I mean, I guess you could see,
hopefully, all right. We'll see what happens.
PowerPoint, how do I share my screen?
I made you, let me make sure I did it before. Let me make sure I did it because you came on and off. Okay, I just made you a co-host. So when you are speaking, now you're good.
Got it.
Dr. Pernicone, I'm gonna guess you don't need to share your screen.
No.
I took a
I can-
wild guess
I can-
that wasn't your
I
thing.
can give you a PowerPoint, but I can't do that here.
Yeah, we're good.
Notice that Mira is much younger. That's the noise that a dinosaur makes.
No, I think you're fine. No worries.
It's not that impressive. The PowerPoint literally just words.
I haven't done I mean, I've tried to do screen sharing. I haven't done like a whole PowerPoint, but I feel like I could do it if I had to.
I have languished through a week. I teach an algebra class
Oh
to
gosh.
some at the Jewish girls high school. That's just kind of, there's a learning pod that we're doing, but because of Sukkot and we needed to have the kids stay at home for a week, I tried to do this by a Zoom, And thank God I have an adult daughter who knows how to work the computer. But even still, the girls will tell you, nobody's looking forward to class more than I am on Monday in person at the Jewish Center, because I can't do
gosh.
this.
Where is the school?
Well, we're having classes at the JCC in South
Oh, nice.
Orlando.
Very
Yeah.
nice. I didn't even know that was there, that they were doing any kind of, a high school kind of a situation. That's wonderful.
Yeah.
Hi, Randy, welcome. You're muted at this point, just so you're aware.
I'm unmuted, yes.
Welcome, welcome.
Thank you. Don't mind, I'm trying to clean up a little bit here.
Go right ahead.
We're in the middle of a renovation in our house, so.
Oh, gosh. Now, are you local?
Yeah, I'm in Orlando.
Oh, cool. Where in Orlando are you?
East in Avalon Park.
Aha. Very pretty out there. Very nice. Well, I'm really glad you're with us, and I think that'll be great. We were just saying, I don't know how many people. It's the time or what's going on in the world. We'll see, how many people, but we are going to do Facebook Live, so people,
Okay.
We know people watch it afterwards a lot, which is fine.
Great.
So we'll do our thing, and we'll see what happens, and we'll wait till 10 and then we'll get started.
And Carol, just a heads up, if my horse out there starts running, I'm going to have to go get her.
Oh my God.
Yeah, after I do my little thing. Yeah.
How is she doing?
She's great. It just lots of energy, and I don't have barn help today.
Oh gosh.
You said a horse?
Yeah, she does. She's a very, very much a horse person.
Wow.
Yeah,
Yeah.
like a major.
different.
We're not talking about like a little horse. This is a major horse
Oh my
person.
gosh. That is
That's
so
why
cool.
when we met, we connected immediately.
Mhm.
I was like, horses?
For many other reasons as well.
And for many other reasons, yes. But that was like
Instant.
amazing.
Yeah.
Do you
It's-
show horses?
I do. And I just got a new horse. It's a 4-year-old from Germany, and she's part German and part Dutch. She's a great, beautiful, big, leggy girl, and I'm very excited.
Is she of a particular breed?
She's a sport horse, and she's meant for dressage.
Okay.
Yeah.
Beautiful.
Yes. Have you set at any dates where you're going to be doing any competition?
I'll probably start in Ocala, and then I'll head down to Wellington, and yeah.
You'll have
Ocala.
to let me know. And my friend Jill there will have to make another trip up to Wellington. Up to Ocala. We did that once. Jill and I I dragged her to some horse show in Ocala, and we sat there. This was years and years ago, but it was fun. It was kind of fun. So
Good.
yeah, we'll come watch you.
You're good. Somebody will.
Yeah.
So 2 more minutes. 2 more minutes, and nope. We've been recording this whole time, I guess.
Excuse me. Oh, I'm so sorry. Oh.
I guess I have to go back onto Facebook and do that again. You were right. It lasted 5 minutes. Let's get this set and then we can start. Next. Okay. Oh, perfect. All right. Before we go live, Danielle, you can hear me? If we can spotlight every time each of the whoever is speaking, if you could spotlight them, please. you don't know how to do that. If you look, okay, I'll show you. So let's say we have the participants and Deborah's going to speak. So you go to Deborah's name, it says more, and then it says, click down, it says spotlight for everyone. So now Deborah is spotlighted. Okay, so that's all for whoever's speaking, that they get spotlighted. I think I'm gonna speak first, just to welcome everybody, and then we'll go to Deborah. And you have the, I think you should see the order of everybody. So I'm gonna go get us live and we'll get started. If I can get out of this. Now I have to get out of full screen, exit full screen, go back to Facebook. Okay, we're gonna, give me 1 second. Okay. Coming back. And we can start admitting people. And welcome everybody. I'm so very excited to have everyone here today for what promises to be a very educational and informative program. I'd like to get started by introducing Deborah Hausman, who is a volunteer for Susan G. Komen organization. Deborah.
Good morning. Good morning, and thank you for inviting me to join you for this very special day. My name is Deborah Hausman, and I am a volunteer for Susan G. Komen, and I'm also the chair for the More Than Pink Walk in Orlando on March 6, 2021. My personal story is about the survivors in my family. My grandmother, my mother, and my aunt are all survivors because of early detection. As a matter of fact, my mother at 92 became a 52-year survivor just this week and continues to credit her doctors by saving her life through early diagnostics. Today, we gather to focus on the topic of Jewish women and breast cancer. We will discuss the importance of screening and the need for routine self-examination and genetic testing. Are you aware that 1 out of 8 women will be diagnosed with breast cancer in their lifetime? Although many believe that breast cancer is diagnosed in only older women, approximately 11% of all new cases of breast cancer in the United States are found in women younger than 45 years of age. Breast cancer is also the leading cause of cancer death among women ages 20 to 39. Breast cancers commonly found in younger women are more likely to be fast-growing and higher grade, which make the cancer much more aggressive and more difficult to treat. This is why age-appropriate education and early diagnosis is so important for younger women. So mothers, please talk with your daughters. It is our goal today to help you clearly understand that breast cancer does not pick a race, a gender, an age, and that becoming your own advocate is imperative for your health. For example, if you have tested positive for the BRCA, the BRCA gene, you are considered higher risk and should seek further screening. You may have joined us because you have a family member or a friend who have experienced breast cancer, or possibly you may be having some personal concerns. By the conclusion of our hour, you will be well informed and have the necessary resources to guide you to better breast health. So please stay tuned because our professionals are about to share valuable life-saving information and provide answers to your many questions because education and awareness are the absolute key to prevention. We hope you enjoy, and it is my pleasure now to introduce Sarah Gittleson. Sarah is the director for Spark Orlando. Thank you.
Hi, everyone. Thank you so much for joining. And thank you to the Jewish Federation and Carol for spearheading this event. Now, if you would ask most people, I think they would say that it's important to make sure that we stay healthy and take care of our bodies. And many people would also say that it's a Jewish value. but it actually goes further than that. Taking care of your health is actually a mitzvah, Jewish commandment in the Torah. And in fact, this mitzvah of safeguarding your health and your life supersedes almost any other mitzvah in the Torah. And I think we learned that the hard way this year when we noticed that the way we celebrate Judaism as a community changed drastically because of COVID. But why is there this like huge emphasis on health in Torah, in Judaism? And there's several reasons, but I want to explain one that speaks particularly to me. And I'm going to explain it by means of a parable. Imagine you buy your child a brand new bike. You spend hundreds of dollars getting this child a top of the line bike. And you give it to your child, your child is always playing with it for a day. The next day, you walk outside and you see that bike lying on the sidewalk in the mud. It's rained the night beforehand. You see rust forming on the bike. What are you going to think? You're going to think, oh my gosh, my child doesn't clearly not appreciate this bike, does not appreciate the money that I spent, does not appreciate the value of what I've given them. Our bodies are amazing, miraculous things. No machine in the world can even close to duplicate the functions of our body. And when we take care of our body, what we are essentially saying is, thank you, God, for giving me my body. And we know that gratitude is one of the major values in Judaism. And that's really what it comes down to. When we take care of our body, we're really essentially saying, thank you to God. So I want you to think about it, right? How many mitzvot you can do when you take care of your body, right? When we go for a jog, we're saying, thank you, God. When we eat healthy food, we're thanking God for the fact that we have our body. When we go for our mammogram or get tested to see what our genetic risks are, we are saying thank you to God. And I want to say to all of you on here today, the fact that you are taking time out of your Sunday morning to come to an event that is going to give you some tools to safeguard your health is a mitzvah. You're showing appreciation to God for the body that you have and showing that you want to take care of it. So I want to thank you all for joining us and supporting each other and joining us in the mitzvah of protecting our health. And I would like to introduce Sarah Florence, who is a musician, a songwriter, an educator, who's going to lead us in some prayer for those that are suffering from cancer and other illnesses.
Hi, everyone. It is so special to be here, and I'm really grateful for the opportunity. Sarah, thanks for inviting me. This is it very much relates to me because breast cancer definitely runs in my family. So I will really enjoy being able to hear and gain more awareness myself. And awareness is key. So I of course, as Sarah mentioned, we're in the midst of coronavirus crisis. So I just want to share with all of you that I personally was tested positive for coronavirus about 11 days ago. So I'm just coming out of it to some degree, but it definitely affected my voice and a lot of other things. And my children also tested positive. So we've been in quarantine, very much so, for the last week and a half, 2 weeks. And so I come to you from my in-laws' basement in Brooklyn instead of from my home studio in Miami. So I do want to just start with I thought it was so beautiful that you guys wanted to bring in a prayer. And I thought we can say the parak of Tehillim, the chapter of the Tehillim, Kuf Chaf Aleph 121. And I don't see anyone. Is there a reason? Oh, there we are. I'd love if you guys wanted to join me from where you are. I'll say one line and you can repeat after me, okay? And then Sarah invited me to sing a song, and I'd love to do that as well. So, Shir Lamalos, Esa Einai El Heharim. We raise up our eyes to the mountains. Me'ayin Yavo Ezri. From where will my help come? I think this is so apropos for our times right now. We're going to pray for ourselves right now. We're praying for all the people in the world that are suffering from anything that they're suffering from, especially the crisis that we're going through right now. Ezri me'im Adonai osei shamayim ba'aretz. My help comes from Hashem, who's maker of heaven and earth. Al yitain lamot raglecha, al yanum shomrecha. He does not move our feet. That's what it means. He will not let our foot be moved. He who watches us will not slumber. Al yitain lamot raglecha, al yanum shomrecha. Hine lo yanum v'lo yishan shomer Yisrael. You can repeat after me. Hine lo yanum v'lo yishan shomer Yisrael. Behold, the one who watches us does not sleep or slumber. Adonai shomrecha, Adonai tzilcha, al yad yaminecha. Hashem is watching us. We have to really, really believe that. Yom HaShemesh lo yakeka v'yareach b'alayla, Adonai yishmarcha mikol ra yishmar es nafshecha. Hashem is watching us and guarding us from all evil. He's watching our souls and our lives and guarding our health. Adonai yishmar tzischa v'wecha me'atav yad olam. Hashem guards us in all our comings and goings and everything that we do from now until forever. I know that through this time, I'm a social worker, and I gave a big presentation on the trauma that so many children and so many of us have gone through. And when we experience trauma, and when we experience crisis in our lives, and crisis is anything that comes to us that doesn't fit in any way in our life, in what we expected, in what we thought would be part of our lives. And so, of course, when an illness comes our way, it's a crisis, and this entire coronavirus experience in our world has been a serious crisis and a trauma. So some of us turn towards prayer, and some of us have a crisis of faith and a crisis of our spirituality. But I want to mention that prayer is not, when we feel out of control, we grasp at everything that can give us a sense of security. And prayer during these times is not at all about appeasing God or asking him, trying to get on his good side, or trying to get rid of something that is going on externally. Prayer during these times is really about centering ourselves, recentering our emotional state, and grounding ourselves. Grounding ourselves in an awareness that God is taking care of us and that he loves us. So I think it's so important for us to realize that when we go there, when we do turn towards prayer, it's to be thankful, it's to recenter ourselves and really turn towards the inner awareness that there's not, that we want to recalibrate our emotional state so that we're not living in fear, and that so we're not living in a place of grasping at control and trying to establish control in our lives in any way we can, because we feel so out of control. We all do at this time. And so that we're just sinking ourselves into this and trying as hard as we can to really let go into a place of, I know that there's something and someone that can take care of me. And so I want to just sing one song, and I hope you'll join with me in that, okay? Thank you.
Thank you so much, Sarah. That was absolutely beautiful, much needed, and we wish you a full recovery. Thank you for being with us.
Thank you.
I would now like to introduce Dr. Mira Iyengar. Dr. Iyengar joined Florida Cancer Specialists after completing her fellowship in hematology and medical oncology at the Warren Alpert Medical School of Brown University in Providence, Rhode Island. She's a diplomat of the board of the American Board of Internal Medicine and is eligible for board certification in medical oncology and hematology. For the past 10 years, Dr. Iyengar has been active in clinical research. She has held various research positions and her work has been published in such prestigious journals as the International Journal of Radiation Oncology, Biology, Physics, Journal of Surgical Research, and the Journal of Pediatric Surgery. She's fluent in 4 languages and is also passionate about volunteering, cooking, Indian classical singing and dance, theater, and travel. Welcome, Dr. Iyengar. You need to unmute. I can tell you that. You got it.
Got it. Thank
Perfect.
you guys. Thank you for having me and allowing me to participate in this. So I was asked to kind of give a brief overview of breast cancer, a breast cancer 101, so to speak. So I'm going to share my screen. I have a little PowerPoint. Can everybody see it?
Mm-hmm. You're good.
Oh, all right, great. So number one, what is breast cancer? So breast cancer is basically a group of diseases in which the cells in the breast change and divide uncontrollably. It's oftentimes seen as a lump or a mass or a nodule that can be felt, but more often than not is found on some type of imaging study. Most breast cancers do arise from the cells that form the milk glands or the milk ducts, although there are other cells of the breast that can also turn into cancer. So what are some of the signs you might see if you have a breast problem? Well, more often than not, breast cancer really has no symptoms, which is why we have screening for it. If you were to develop a physical finding, the most common finding is a painless lump in the breast or in your armpit. Other signs could include breast pain, swelling, thickening of the skin, redness of the skin, any changes to the nipple, any abnormal discharge. You might see some other types of skin changes. In all honesty, any concerning or new symptom in the breast should always be evaluated by your physician. So some of the breast cancer statistics, more recent statistics. So in 2020, it's expected that over 276,000 new cases of invasive breast cancer will be diagnosed in women. And this doesn't include high-risk diseases such as diseases you might hear of called ductal carcinoma in situ or lobular carcinoma in situ, which are non-invasive types of breast cancer. Approximately 2,600 cases will be diagnosed in men. So even though the overwhelming majority is in women, it is a disease that can affect both sexes. Approximately 42,000 women and 520 men are expected to die from breast cancer this year. So what is your individual risk? Well, they had alluded earlier that about 1 in 8 women on average will get breast cancer in their lifetime. There is a slightly higher increase in women of Jewish descent, and that's thought to be due to a higher prevalence of genetic alterations that can put you at a higher risk for the disease. It is estimated that about 1 in 39 women will die from breast cancer in their lifetime. So what are some of the risk factors that we look for? Well, there are some risk factors that we can't change no matter what we do. One is gender. Breast cancer is much more common in women than it is for men, so women are at higher risk. Age is a risk factor, so the older you get, the higher the more risk you have of developing a breast cancer. Caucasian women in developed countries seem to have a higher incidence of breast cancer. Other things, early periods or late menopause tend to increase the risk for breast cancer. If anyone has been exposed to radiation treatments in the past for whatever reason, and this doesn't include routine imaging studies like x-rays or mammograms, but if you've been exposed to radiation and treatment for other types of cancers or diseases, that can increase your risk for breast cancer. There is a lot of genetic syndromes that are associated with a higher risk for breast cancer. The most commonly heard ones are the ones associated with the BRCA genes 1 and 2. Those of Ashkenazi Jewish descent can have a 1 in 40 chance of having a BRCA mutation. So again, family history, personal history are very important. Family, even without a genetic mutation, anyone who's had any family history or personal history may be at a higher risk as well. But what are some of the risk factors that we have that we can potentially modify? So we know that obesity, excess body weight can increase the risk for breast cancer. So do not neglect the importance of diet and exercise in living a healthy life. Alcohol intake has been associated with breast cancer. It does seem to correlate with the more alcohol you drink, the higher the risk. Tobacco use can be a risk factor. Women who've never been pregnant or who have pregnancies later in life can be more at risk for breast cancer. Women who have never breastfed may be at more risk for breast cancer. In fact, it's been shown that the earlier you have your children, the more protective it may be. Use of exogenous hormones, things like hormone replacement therapy during menopause can also increase the risk. So there are some rumors or myths out there that some other things may increase your risk for breast cancer, but it hasn't actually ever panned out. One is abortions. There was a study that looked at that, and that was never been shown whether the abortion is spontaneous or induced. It hasn't been shown to affect your breast cancer risk. Bras, that's often a common misconception that wearing bras might increase the risk for breast cancer, but again, that has never really panned out. And the same thing with breast implants. Breast implants do not necessarily increase your risk for breast cancer. There is a rare type of lymphoma that is associated with breast implants, but not a breast cancer in and of itself. Breast implants can mask some tumors. So it is important that if you do have breast implants and you're getting routine screening, that you let your mammographer know so that they can take extra precautions to get good views of the breast. So how do we screen for cancer? Well, we have 3 major modalities by which we can image the breast. That's the mammogram, the ultrasound, and the MRI. The general population usually start with mammograms. So mammogram is basically a low dose x-ray that takes a picture of the breast. If you can see in this lady here, the breast is put between 2 panels, and the paddle is slowly kind of compresses the breast, and you get a picture kind of like the one on this side, and you may see abnormalities in the breast that way. As you can see, it's not the most comfortable of procedures, but it does give us, it is a great screening tool that has reduced the mortality and morbidity associated with breast cancer. Ultrasound is using high frequency sound waves to look for abnormalities in the breast. So basically you'll get put with the use of gel and a transducer probe. They can image the breast tissue and look for any abnormalities in that respect. Ultrasound in and of itself is not a screening test, so doing it all by itself is not very useful. It is usually used in conjunction with a mammogram, and it may be particularly helpful in women who have very dense breasts, where the breast tissue is very, very thick or very dense, and it can give you a better picture or more added information. The last modality we have is MRI, which also, like the ultrasound, is not usually in and of itself a screening method. We usually use it in conjunction with mammograms. There are women that are at a higher risk for breast cancer, and it is recommended that if you have a risk for breast cancer that's over 20% in your lifetime, that an annual screening MRI should be combined with a mammography in those people. Those who have kind of an in-between 15 to 20% lifetime risk, it's more of a risk benefit. Some insurances may or may not cover it at that rate. And those who have less than 15% chance, usually it is not recommended. MRI, again, should not replace a mammography. It's used often in conjunction with a mammography, not necessarily at the same time. You usually will split them every 6 months, do an MRI alternating with a mammogram. So when do we actually start screening for breast cancer? So most people, if you're at average risk, run of the mill, you start at age 40. Women ages 45 to 54 recommend annual mammography, in addition to any other imaging that might be necessary. Women who are age 55 and older, they do have an option of getting screened every 2 years versus annually, although I will tell you in my practice, I generally recommend annual mammography. The question always arises, when to stop screening. So typically my recommendation is if your overall health is good and you have a life expectancy of at least 10 years, I would recommend getting screening. So even if you're 90, but you're great, you're doing well, I don't think it's a bad idea to get mammograms. So number one thing that I kind of want to leave you with is to be familiar with your body. All women should know the appearance of the breast, what they look like, the size, shape, anything, so you can report any changes promptly to your doctor. If you do develop any symptoms, contact somebody immediately. When we do have an abnormal exam, if cancer is suspected, we do a biopsy. And this is kind of an example of how a biopsy is done, where they put a needle into the area of concern and they get a piece of the tissue to analyze it under the microscope. And then based on what we see under the microscope, if cancer is diagnosed, we have to look at something called the receptor status, and that helps us determine the best treatment strategy for a patient. And there are 3 big markers that we look for in breast cancer. So if you ever read about breast cancer, you'll hear about this a lot. 1 is the estrogen receptor, 2 is the progesterone receptor, and 3 is HER2. These 3 proteins that can that can be involved in the breast cancer cell are important because we have treatment modalities that are directed against these. So estrogen and progesterone are the predominant female hormones, and they can be stimulatory to breast cancer. So if you are estrogen positive or progesterone receptor positive, then you may be a candidate for treatments that will block the effect of hormones on the cancer cells. HER2 is another protein that is used to help the cells grow. And we do have a targeted drug for HER2 proteins, which is why it's an important marker to know. So if it comes down to it and you need some treatments, we have 4 main modalities of treatment. Number 1 is surgery, where we just get the thing out. Number 2 is chemotherapy. Chemotherapy is the type of drugs you think about when you think about chemotherapy, conventional chemotherapy. That means the stuff that causes hair loss, nausea, vomiting, diarrhea, all those side effects that you see on most shows and things. Chemotherapy is not necessarily needed for everybody. It is definitely individualized, and we have tools that help us determine who may or may not need chemotherapy. The third modality is radiation therapy. That also is not always needed, but it does. There are a lot of tools and other factors that go into making the decision as to whether radiation treatments are needed. Radiation is a treatment where you are getting some type of radiation beams directed towards the local area where the cancer was. And then the third type of treatment is endocrine therapy, which is the anti-hormonal therapy. So as I mentioned earlier, with estrogen receptors and progesterone receptor positive cancers, endocrine therapy is an important mainstay in helping prevent disease recurrence. So in summary, breast cancer remains a significant cause of cancer and cancer death in women. Routine screening with annual mammography and other imaging modalities can decrease mortality and morbidity from breast cancer. Breast cancer treatment is multimodal, with surgery, oncology, medical oncology, radiation oncology, all playing a role in the treatment. And therapy is definitely tailored to each individual person and the preferences of a patient. So that being said, I'm going to
Thank you. Oh my gosh. Dr. Anga, that was amazing. Amazing information presented like absolutely perfectly. That was so good. If people have questions, you can put them in chat. Maybe Sarah, you could do me a favor and check on Facebook if you see for any reason, if anyone has any questions come up on Facebook, that would be great. And then we can always even take questions at the end from people. You can see her information is in the chat, how you can contact her. And again, we will post all of that at the end and it will be available for everyone. Again, thank you so much. Emily Goldberg is next. Emily is a genetic counselor at JScreen, which is a nonprofit organization through Emory University, whose goal it is to help prevent genetic diseases. She graduated from Sarah Lawrence College with a master's degree in human genetics and has been practicing as a prenatal and cancer genetic counselor since 2011. She serves as an instructor at the Albert Einstein College of Medicine and adjunct faculty at Sarah Lawrence College. Welcome. So
Thank
glad
you.
you're here. Thank you.
Thank you so much. And thank you for having me. I'm just going to try to share my screen and hopefully this is going to work. Can everyone see that? Perfect. All right. So basically what I want to do, this is a great follow-up to Dr. Einger's talk. And, you know, people have alluded a little bit already to the genetic factors that contribute to breast cancer risk and also other types of cancer. So what I want to do is just give you a little bit of information about what some of these genes are, what it means for people who have these genetic mutations, and how this information really can be a powerful tool. So I think I don't have to go into this too much because, you know, we just went through some of the different risk factors, and most causes of cancer, most people that have cancer, it's not caused by something inherited. It's often sporadic, associated with some of the risk factors that we just heard about. But for some families, the smaller slice of the pie really is associated with a hereditary or genetic factor that contributes to someone's cancer risk. And we all have genes, everybody has them, and their job is to, this category of genes, their job is to protect our bodies from cancer. So they're like security guards. They're looking for errors in our cells and the development of abnormal cells, and they try to fix it before it becomes a problem. So it's our body's natural way of protecting itself. And sometimes in a family, we find that one of these genes doesn't work right. So there's a mutation, which means there's a change in a gene, meaning that it can't do the job that it's supposed to. So we lose some of that protection. So families who have that have higher risks for certain types of cancer. So some of the things that we look for when we have this going on in a family is a lot of family members in multiple generations who have cancer. We may see cancers diagnosed at a younger age than normal. We might see one person with more than one type of cancer, or certain types of cancer that can go together, like breast and ovarian cancer. And the way that these run in the family is something that we call dominant. So we all have 2 copies of every gene because we get a set from our mom and we get a set from our dad. And we definitely don't want to forget about dad's side of the family because we do get half of our genes from that side. And so if somebody has a change in a gene, then for any children that they have, there's a 50-50 chance that they would pass it on and a 50-50 chance that they would not. And this is part of the reason why family history is so important, because we look for clues in the family to figure out not only if somebody should or shouldn't have genetic testing, but to figure out what kind of screening and what measures may be useful for them. So BRCA1 and 2, most people have heard of as they're the most common genes associated with breast and ovarian cancer risk. And when somebody has a genetic change in this gene, aside from the risk for breast and ovarian cancer, we can also see higher rates of male breast cancer and prostate cancer, as well as risk for pancreatic cancer and melanoma. And you can see from this diagram here, the risks really are dramatically higher for people that have a BRCA mutation. And so I'll talk in a few minutes a little bit about what we can do with that information. But this is something that is useful for someone to know that they have a higher risk so that there's more that they can do about it. The other thing is that BRCA mutations are about 10 times more common in people with Ashkenazi Jewish ancestry as compared to the general population. So even without knowing anything about somebody's personal or family history, when somebody is Ashkenazi Jewish, it means right off the bat, they have about a 1 in 40 chance to be carrying a BRCA mutation, even if they don't have a family history. Now, it's also important to note that if somebody's had BRCA testing in the past, that those aren't the only genes responsible. It used to be the main ones that we knew about and the only ones that were available for testing. But now we have a lot more information about how other genes can play a role in breast cancer risk, as well as other types of cancer. Now, the good thing about doing genetic testing is the reason we do it is because knowledge is power. If we know that somebody has a higher risk for something, then we're more prepared and we have that information behind us that we can use to make choices about how to keep somebody healthy. So this could include things like preventive surgery, so removing somebody's ovaries or having a risk-reducing mastectomy to reduce somebody's risk later on. It can also include extra screening. So you heard a little bit about adding breast MRIs into somebody's screening protocol. So this could certainly be an indication for that. And then you can see here, there's a list of other types of screenings for other types of cancer as well. So by knowing this information and knowing somebody has a mutation in a gene, we can really personalize their medical recommendations. Because again, the idea is to catch things at an early treatable stage or prevent it if we can. Another thing that may be useful for women who are doing genetic testing and want to think about their family planning is some couples may choose to undergo something called in vitro fertilization with pre-implantation genetic testing, which is a bit of a mouthful, but basically what this means is that a couple goes through a fertility process called IVF, where they create embryos in the lab, and you can actually test each embryo and select for a genetic condition, such as a BRCA mutation, and select embryos that are found not to have that condition. Now, as a genetic counselor, what I do is I help patients understand what genetic testing is, what it may mean for them, if it's going to be something that's useful for them in their lives, and help to explain it in a way that they can understand and make a decision about what they want to do and what they would do with this information. So I do recommend for anybody considering genetic testing to definitely talk with your doctor, meet with a genetic counselor, and really understand what this could mean for you and for other family members in the future. Just to give you an idea about our process, so JScreen is an organization that provides at-home genetic testing. So there's a lot of different options to test for BRCA and some of these other genes. JScreen historically has done carrier screening, testing for diseases that affect offspring like Tay-Sachs, but we're actually about to launch our cancer genetic program, where basically somebody can go online and they can request a kit, and we do get a signed order from a healthcare provider, depending on the state that you live. And you'll get a kit in the mail and you spit in a tube and you send it off. And then once those results are ready, you meet with myself or another genetic counselor to go through what we found with those results, what that information means for you and your family. We could talk about different actionable plans as far as what to do with that information, if we'd recommend other people get testing, and really just make sure that you understand what this means for you and how it can be used. So I just have some information here so you can learn more. Again, we're launching it in the next couple of weeks, but feel free to sign up so you can have some other information. The different tests that are out there are not necessarily created equal. So as I said, sometimes people are tested for just one gene. Sometimes it's a whole span of 20, 30, 40, 50 genes. As of now, we know of about 20 to 30 genes that are specifically related to breast cancer risk, but there are also other genes out there relating to colon, ovarian, pancreatic, melanoma, other types of cancer as well. And so some of these newer panels encompass a lot of different types of genetic tests. So again, an important part of this is figuring out what your family history is. Would genetic testing be useful for you? Sometimes people choose to do genetic testing as a preventive measure, even without a family history, because they feel that that knowledge would really change how they manage their risks, and they want to know as much information as possible. So don't feel that you have to specifically have a certain kind of history or have to wait until someone gets cancer to undergo genetic testing, because really our goal is prevention and knowledge, and to keep everybody and their family as healthy as possible. So again, thank you so much, and certainly I invite any questions you may have.
Thank you so much, Emily. I know there are people watching on Facebook. Sarah, are there any questions or anything that we want to get to now, or people can post and we can get to them later also?
Sounds good. Thank you.
Do you see
I'll
anything,
post
Sarah?
I don't, but I'll post in this chat. if
Okay.
anyone- That way it's all in one place.
Okay.
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 Oh, and I actually did get a question in the chat that says, is there a difference between a saliva test and a blood test? And that's a great question. The accuracy is the same because we carry all the same DNA in every cell of our body. The only difference sometimes is with spit. If there's not enough cells in the sample or something like that, sometimes we have to repeat it or anything like that, but it doesn't affect the accuracy. Just every once in a while, someone has to repeat their testing.
I do have Sarah, you must be on yours, on the Federation Facebook page. We do have a question. If a mom tests negative for BRCA, does that mean the daughter is BRCA free?
That is a great question. So for starters, in general, yes. So if somebody has a genetic mutation, there is that 50% chance that they could pass it on to their children. If they don't have it, they can't pass it on. Sometimes you hear genetic skips a generation, and sometimes it looks that way. But as far as having an actual mutation, it doesn't jump from one person, a grandmother to a grandchild, for example. So if somebody is negative, then they can't pass it on to their children. That being said, we can also inherit these mutations from dad. So it's important to be aware of the paternal side of the family history. And if there is a significant family history, then, and they've only had testing for BRCA1 and 2, they may consider doing genetic testing for other genes as well, because there could be a mutation in another gene that's contributing to that family history risk.
There is another question. Thank you. Thank you very much.
Welcome.
In fact, I had that very situation in part of my family. A daughter is positive, the mom is negative. Turned out she got it from her dad.
Mm-hmm.
So there is another question. If the daughter is negative but mom is positive, does she have the same risk as the general population, or should she still get early screening?
So that's another great question. So if the daughter tests negative for a known mutation in the family, they're in the genetics world what we call a true negative, which means we know why their mom or their maternal history has these cancers, and the daughter didn't inherit that mutation. She's considered at the population risk for breast and other associated cancers. Again, if there's something on the dad's side of the family history, that still has to be taken into account. And she should still continue with routine mammograms and other breast cancer screening based on her health. But we wouldn't expect her risk to be any higher than the general population.
However, if I may interject something.
Of course.
Okay. If the mother had breast cancer at a young age, say at age 40 or age 35, we want to back up the hands of time and have that daughter obtain her baseline mammogram 10 years before her mother had gotten breast cancer. And then we can screen her on an as-needed basis, but perhaps a mammogram every other year or every 3 years in her 20s. But then when she became 35, or in fact 30, we would move to annual mammography, even though she technically doesn't meet the age criteria for her annual screening to start at the age of 40 when we traditionally do it. So it does matter on the age of onset of breast cancer in the mother, even though the daughter tests negative, because certainly we have hereditary patterns that are not known genetic mutations.
Thank you. That was very all important information everybody is doing. It's amazing. Getting great feedback on Facebook and from people texting actually. So thank you, everyone. Thank you so much, Emily. And we're going to move on to Brianna now from
We
Sharsheret.
have one more question that was.
I'm
just
sorry,
posted.
go right ahead. Oh, there it is. I see
yeah.
it. Okay, do you recommend another test for other mutations if positive for BRCA? I had breast cancer at 36 years old. Testing was done a while ago from Stacy here. She's on
Okay,
Emily.
Yep,
You can see it. You
I
can see the
that here.
question.
Yep. So that's an interesting question because historically we would say we found the reason, the breast cancer was caused by this BRCA1 mutation. So I think many people in that situation would stop assuming that we found the answer, and that would be more than reasonable. That being said, in very rare cases, we have found families that have more than one mutation. So it's something that could be considered, but certainly not mandatory.
Okay, thank you. And again, if people have questions that you're thinking of afterwards, put them in the chat, put them on Facebook. We'll try to get to everyone at the end. If we don't, you can always contact people afterwards. They can answer your question. Brianna is Sharsheret's Florida. Thank you again, Emily. Brianna is Sharsheret's Florida Regional Director. She's a graduate of University of Florida and manages the daily operations of Sharsheret's Florida Regional Office and coordinates education and outreach efforts and collaborations with Jewish cancer and campus organizations throughout the state. Brianna lives in South Florida with her husband and 3 daughters. Sorry, my dog, I'm muting myself.
Hi, good morning, everyone. It's nice to be here, be back with the Orlando Federation. I'm Brianna Schwartz. I'm with Sharsheret, and we've heard some really great information already this morning. And I kind of want to let you know about Sharsheret's resources that are available so that you know what type of support services are available within our Jewish community. So a little bit about Sharsheret. We're a national organization. We are fortunate enough to have a regional office in South Florida, but as the Florida director, in normal times, I travel all over the state. I've been in Carol's office a bunch of times in the last year. And because Orlando has such a vibrant Jewish community, we want to make sure that we are providing support throughout the state. So we're a national nonprofit organization. Our mission is to improve the lives of Jewish women living with or at increased genetic risk for breast and ovarian cancer through personalized support. And we save lives through educational outreach. Programs like today are planting seeds so that you know about breast cancer risks, you know about what you need to do to be proactive about your health. You're planting that seed so down the road, you'll know what to look out for, what questions to ask your healthcare professional, and then what support services are available if you have additional questions. So Sharsheret plays a really interesting role in the breast cancer and Jewish communities, in the cancer and Jewish communities. So in the Jewish world, we play a really, we are the go-to organization for cancer questions in the Jewish community. We're also in the cancer world, we are the go-to organization for questions about the Jewish community. So the two, we play a really interesting role, and we try to really educate populations about all of the information you heard about genetics and how that plays a role in Jewish women of Ashkenazi descent. So the most common question I get at Sharsheret is, how do you say Sharsheret, or what does the name mean? The name Sharsheret was chosen because it is the Hebrew word for chain, and we are linking women, Jewish women and families facing breast and ovarian cancer. The second most common question I get is why? Why the need for a Jewish organization? What makes us so unique, so special that we need a whole organization just for ourselves? I think based on Emily's talk about genetics, you can hear, I don't even have to go into that. She already has. That's a great reason for there to be an organization specifically for our population. We talk a lot about the need for an organization like Sharsheret when you're thinking of culture, spirituality, values, the holidays. We notice at Sharsheret around September, October, September more, we get a spike in our call volume. And it's not because the weather is cooling down, it is because it's the high holidays are coming up. Imagine you are a woman who knows that you have an increased family risk, or you are facing breast cancer, or you're going through treatment and the high holidays come. That's a time where we're reading prayers and we're learning about who will be stamped in the book of life for the next year. As a Jewish woman, to sit there and wonder, is this the year I'm going to be diagnosed? Am I going to get through my treatments? Will I be stamped in the book of life? That prayer about who shall live and who shall die is a huge trigger when you're talking about facing a cancer risk and being a Jewish woman. So that we always know that around the holidays is a real difficult time for many women in our communities. And so that's why we know that we need a little extra support around this time of year. We talked a little bit about values in the beginning of this program and the value of maintaining your health and taking care of your body. That's a Jewish value. And so it's really important that we are taking care of ourselves. We get questions from women in the community who know that pikuach nefesh, which is the idea that preservation of human life supersedes everything else. That's a Jewish value. It's important in our world. So when you're talking about cancer and cancer risks and genetics, is saving our lives what constitutes as something that is saving our lives? What can we do to really maintain that Jewish value in our lives? Women call us for questions about dating, marriage, and the concept of community. Especially being on a call with a Jewish Federation, everyone on here feels a sense of community. That's why you're part of the Federation and a JCC and this vibrant Orlando community. So how can we as a community support one another when we are facing diagnosis? And I think a program like this morning is just a perfect example of how that community comes together to provide education and to provide support. Sharsheret really is wherever you are. So we have expertise in patient-centered cancer care for Jewish women. We have social workers and a genetic counselor on staff. So when someone has questions or someone is newly diagnosed and they want to understand their new language of cancer that they're speaking, they can call and speak to a social worker or a genetic counselor and speak to a professional who can help them navigate through these new uncharted waters. When we get calls from women who say, I know I'm at increased genetic risk, is testing right for me? Or someone in my family was recently tested and I have questions, they can call us and we are able to provide them that support and information from trained professionals. We service more than 150,000 women and families from all Jewish backgrounds, however you identify, whether Orthodox, conservative, Reform, just Jewish, I only celebrate the holidays. Sharsheret is there for you. It's important to note that while our expertise is in the Jewish population, Sharsheret supports everyone. We estimate about 15 to 20% of the population we serve are not Jewish. It's just that our area of expertise is in this population. But if our services speak to you, we're happy to share them. We have peer supporters who I'll tell you a little bit more about on the next slide. We partner with healthcare professionals, with Jewish organizations, with hospitals, with cancer centers. And we're also connecting with college campus, college students, because we know that the young adults of today are the adults of tomorrow. And so we want to make sure that they have that education too. So how do we do all of the things that I've already mentioned? How do we support women? Our peer support program is the meat and potatoes of Sharsheret, we like to say. What it is we're able to match women one-on-one with those who have a similar diagnosis, connection to Judaism, stage of life, treatment options. We can connect women on a bunch of different ways. So if someone calls us and says, I'm newly diagnosed and these are my concerns, we're able to match them with someone who had similar concerns or has a similar background. And like I said, we have over 10,000 women in our peer support network. So, and it's national, it's always been over the phone and online. So especially now when people are staying home, they're still able to access all of our services, especially the peer support network. Genetics for Life, like I mentioned, we have a genetic counselor on staff. And so we can answer any questions you have about family history. What if testing is right for them? And a lot of the questions, I think our genetic counselor is probably one of our busiest staff members. We have an entire program for those living with ovarian cancer because they have unique concerns different than those facing breast cancer. We also have resources for women living with advanced stages of cancer. So someone who's learning to have a lifelong relationship with cancer, we have support services specifically for them. We also know that when a woman is diagnosed with cancer, she is not the only one who is going through a cancer journey. Her family is, either her parents, her children, her community, her friends, they're all going through it together with her. And so we have resources that help caregivers. Our Family Focus program specifically has resources for caregivers in a woman's life to be able to help them provide support to the woman going through cancer. Our Busy Box is one of the most beautiful programs I think that we have, where we provide age-appropriate toys and activities for kids to do while mom is resting or mom is in treatment or mom just needs a minute. It also comes with resources for parents on how to talk to your kids about cancer. So you can have conversations with your kids at different ages, whether they're 5, 15, 25, how to have that conversation with your children. Best Face Forward is a program that addresses the cosmetic side effects of cancer, and it's all natural, paraben-free cosmetics to help you look good and feel good while you're going through cancer treatment and you don't look like yourself. And then Thriving Again is a program we partnered with the CDC. Sharsheret receives funding from the CDC, from the Centers for Disease Control and Prevention. And this was from a grant from several years ago where we created a survivorship kit for women who are, because once your cancer treatment is over, that doesn't mean cancer is completely out of your life. Thriving Again focuses on a healthy lifestyle post-cancer. So exercise, eating well, making sure that you commit to regular screenings afterwards. All of that is in our Thriving Again kit. It's also important to note, because I mentioned the CDC, Sharsheret chairs the Federal Advisory Committee for Breast Cancer in Young Women. So we also have a seat at the table when we're talking about resources nationally that are available to women facing cancer. So we have a seat at that table. It's very exciting for us. And then we do a ton of education and outreach. We do Sharsheret supports. We partner with local groups in different communities. We have an educational booklet series. I believe it was going in the chat, the resources that we have available. You can download all of our resources are on our website, so you can download any of our booklets and read them from the comfort of your home. I mentioned we do a lot with campuses, so our Sharsheret on Campus program addresses that. And then we do healthcare symposium. We do programs, webinars. We used to do them 4 or 5 times a year. Now we're doing them like 2 times a week because we're seeing the need for information out there online, especially during this time where people are home and they're looking for resources online. I'll give a plug that tomorrow night, Monday night, we're doing at 8 p.m. We're doing a webinar on how to create your personal screening plan. So it might be a great add-on to what we're learning today about genetics and everything else. You can log into Sharsheret's webinar tomorrow night about creating that personal plan. If you are interested in getting more involved with Sharsheret, there's a lot of different ways that you can bring breast cancer awareness to your own neighborhoods, to your communities. Holiday, a Pink Shabbat, a Pink Day, panel discussions. We really want to share the information that we have and get it out there into the community and let as many women know about the importance of awareness and screening and knowing their genetic risk and their family history so they can make educated decisions about their health. These programs that we do in communities really get the word out. So you're ambassadors for sharing that information. Lots of other ways to get involved, whether you want to get Team Sharsheret or action for any of the boxes I mentioned. And I encourage you to connect with us. Follow us on Instagram, follow us on Facebook. We have a YouTube channel that we're always posting videos from women who are sharing their stories. If you have any questions, we're here for you. Our website, we have a 24-hour person on our website that answers questions. So If you have any questions about Sharsheret or about information that you learn, we're happy to be there as a resource for our Jewish community.
Thank you so much, Brianna. Appreciate all that information. Again, you have obviously the contact information here, and we will post it again later. At this point, I would like to introduce Randy. Randy Ballard grew up in the Orlando Jewish community and now lives here with her husband and 2 children. Randy tested positive for the BRCA2 mutation several years ago and underwent several preventative surgeries. She became involved as a peer supporter with Sharsheret and with Force. She will share her personal story with us today. Thank you so much for being here, Randy.
Thank you for having me. Good morning, everyone. I was just going to really go through kind of my story, preventive story versus having the cancer diagnosis and why I chose what I did. I actually wanted to get a lift after breastfeeding 2 children. I thought the girls needed a little help. And so my friend, who actually was the same age as me, her mother had passed of ovarian cancer and her aunt also passed of ovarian cancer young. She said, you know, aren't you an Ashkenazi Jew like me? She said, I think you should go get some testing done instead of going backwards. You're going to get this, you know, lift, and then you're going to get tested. And what if you have this gene and then you're going to have to get everything fixed? So I actually did it by a chance of my friends saying I should do something. I thought about it a little bit harder. My mom's mom was young and died of breast cancer in her diagnosed early 50s, past 60, but she chose no treatment. And then I was thinking about further. I have cousins with colon and bone cancers, and my mom's side is ridden with it. So it kind of made me think that I should probably get this testing done. I was 30, almost 38, done with kids, and the 1 in 40 number that we've all been hearing jumped out at me, and I went and got it. And my genetic counselor called me. Actually, my OB had one on staff here in Orlando, so it was kind of easy. I said, hey, remember me for baby genetics? Now we're doing this genetics. And said, come on in, and called me 2 weeks later and was like, you're a BRCA2. And I literally kind of was shocked because I only did it because my friend said something. So after talking to my friend, Force is also another organization along for anyone with mutations and different mutations, not just breast cancer only. And it happened to be in Orlando the next weekend after my diagnosis. So I decided to go with my girlfriend to the Force conference and learn from doctors and geneticists and everybody across the country come to this meeting. Information overload, but also, like we've heard today, just gaining information and having knowledge is power. So after the conference, by profession, I'm a financial planner. So if anybody knows me, I'm slightly OCD. I plan everything from top to bottom. And the only advice I would suggest to anyone looking for preventive surgeries is to actually have a plan. I try to tell when I peer counseling to not feel like you're a ticking time bomb, that you found this information today and you need to do something tomorrow about it. I think if you didn't take the test, you wouldn't know. So you really should take your time because it is an extensive surgery. It is a mastectomy. So I did decide to have a double mastectomy at the age of 39. I had a 2 and a 4-year-old who was going to teach my kid to get in a high chair, get in a car seat, go into the crib, so there were a lot of things on that planning side that I had to do. I also chose a doctor who pioneered one of the surgeries that I had in New York City. So I flew from Orlando to New York and spent 2 weeks in New York City with my plastic surgeon, who is the medical director of Mount Sinai. And he, in my opinion, he's Jewish. There was a lot of things. We connected. He was Jewish. He was warm and good bedside manner, and he pioneered the surgery. So when someone asks me what types of surgery, there are lots of types of reconstruction or not reconstruction. A lot of things have advanced and changed. I remember hearing Angelina Jolie's story 15 years, and I was like, this lady is crazy. Like, what is she doing? And then I realized I'm that crazy lady going to follow right behind her. So I can see why it's important. When I met with my genetic counselor, my risks were 75% in my lifetime of that I would get cancer. So based on my family scenario, all these people on my mom's side, my not genetics, my hereditary risk, along with the BRCA2 risk is kind of why I made my decision. I made my mom, who was not happy about any of this, by the way, go and get tested. And she went to my geneticist in Orlando and she was negative. So when everyone talks about the dad side, I find it so important for you to check both sides, and they don't need to check. I mean, one person needs to check, or my dad wasn't my dad. We joked around, like, I'm like, well, Dad, if it's not you, then you're not my dad. So, so then you really need to know your dad's side. So all that history on my mom's side gave me my family risk and then this risk. So I also would suggest a couple things with preventative surgeries. Also, even getting genetically tested. Once you're genetically tested, as an insurance agent too, because I'm a financial planner, so it does, I'm not saying you can't get insurance, you can, but it does, if you're looking for separate policies, once you have that marker on you, it does increase your costs. Meaning if I wanted to get an outside policy, some kind of whole life policy or term policy, they will actually charge you because now that's in your file, your medical file. So that's why I say you have to plan. Before you get the test, I would make sure all your matters are in place financially, that regards. You get this test, and now what do you do for the next? So back to my mom getting tested and finance my dad. My mom was kind of against it because the way I remember mastectomy was a big scar across your chest. Sometimes people choose not to have recon, so flat. And I think the images I see of mastectomy were very drastic. So it has changed. It has really changed. So I'll tell you why I picked my doctor. I think you have to determine whether you want implants or not. Because if you want implants, there's the expander method, which is they call it like a wire bra that gets put into you, and it's inflated to stretch out the skin before they put implants in. So it can take a couple months to get that done. Or you can do what I did, which was direct to implant, which was my breast oncologist surgeon was right there with my plastic surgeon. They take out the tissue, the fat, and then my plastic surgeon's right behind the breast oncologist and puts in an implant. My cut is inframmary underneath, so you don't even see. And I also chose skin and nipple sparing. So my doctor believes if you are a true preventative case, you should keep your nipples. That's a big discussion in the preventative world. Should you, does it leave a little bit of breast tissue, what have you? So I did nipples and skin sparing with an inframmary cut. So you see nothing. When I look in the mirror, I look like I did when I was 16, actually, a little bit better. So that's the difference. My best friend, who is also BRCA with, I told you earlier, with her ovarian risks, she chose a flap surgery. So deep flap is very popular right now. It's basically taking the skin from your stomach, not taking the muscle, just the fat and the tissue, and recreating your breasts without using any type of foreign object. So I always tell women, when you're making your choice, you have to determine, do you want an implant or not? Right. That's really where it comes down to on the recon side. And then I would think for anyone, for the planning piece, your children, they call it T-Rex arms. I couldn't reach up like into like cabinets and things. So my arms were kind of like stuck to my body for a while. Washing my hair was kind of like this for a little bit. But it's the same thing, someone with cancer, without cancer, the mastectomy is the same. I mean, it's still very invasive. It's a lot of healing time. I couldn't drive for a month. So if I also wrote a blog, and I work for a couple different cancer charities here in Orlando. So I was going to attach my blog. So if anybody has questions about the entire journey from beginning to end, you can read it there. I'm very open. My pictures are on there. So everybody likes to see what the options are. I think seeing current. So when you go to a plastic surgeon, that was what I even said to my surgeon. I was like, how old is this book? Is this like a 30-year-old book that I'm looking at for recon issues? So I think it's important to talk to women now who've had it done, and so you can feel good about yourself in the end. As for the lower half, so fast forward my story a few months later, my cousin called me from LA, a boy cousin, and said they found he had pancreatic cancer, and he was 42, and no one in my family had pancreatic cancer, and we got him genetically tested, and we found out we're the same family mutation. So what happened was, it's my dad's side. nobody on my dad's side has cancer, but they're all men. So we never put 2 and 2 together that maybe we should be screening the men and my father and the cousins and everything. So I flew up to see him in LA. Sadly, he didn't make it. He only lasted 3 months from diagnosis to the end. But then I was nervous about pancreatic cancer. Like my mind started ticking like, okay, I did this, but what about the rest? And what do you do for pancreatic cancer? So there are other screenings besides just the regular genetic testing. They do some blood work testing like CA125 and CA19 for different types of blood works. They're not very accurate, but it does give us some numbers and a baseline. So I went and had an MRI CP of my abdomen area because I was so nervous, but my doctors here at UF Cancer Center said, listen, you're a female though, we're way worried about ovarian cancer for you more than pancreatic cancer. So I said, listen, I need to stay married and I don't know if I want you to go into surgical menopause by the age of 40 years old. So I'm a little nervous about going through surgical menopause. So she said, let's do steps because by being BRCA2 by the age 40 to 45 is when you should have your surgeries. So since you're 40, I'm okay with what you're okay with. So I ended up taking out my tubes and 1 ovary and a laparoscopic surgery that same year. And that's not for everyone. Some people just want it gone and don't want to have the worries about the other and still do screening. So I ended up doing that because there's a lot of studies coming out now showing that ovarian cancer is starting in the tubes. And there are even studies out there like the WISP study that I'm a part of that's showing that let's see if we take steps to it. Is it maybe that a way to do it instead of saying, take out your cervix, your uterus, your ovaries, your tube, like taking everything out because you still have perioneal risk cancers. So I chose to just take a step at this time for me. But obviously seeing my cousin, that kind of amplified everything for me too. So I have done both. I did those 2 years ago. And I feel like if you have to find what you're okay with and what steps you want to take. Doctors can sometimes be forthcoming and say, these are the odds and these are the statistics and you need to do this. And I said, I needed to find somebody that would let me do the steps that I was comfortable with going forward. So like I said, I would put my blog up, have questions, you have anything you want to ask me separately. I know a lot of people like to talk offline about it because it is a very personal decision. I'd be glad to anytime speak. And that's what I do pretty much 2 to 3 times a week with lots of women around the area. And that's what I enjoy to do because it is a scary decision. And I really enjoy telling people that it's okay to be scared and it's okay to have a plan in place to go forward and knowing you're not alone. There's a lot of people out there.
Thank you, Randy. That was amazing and informative and inspiring and all these other words. And I can't thank you enough. Would you be so kind as to post your information in the chat? I didn't even think to ask you for it ahead of time. I didn't know you had all that.
No worries.
So please, if you just post it so people have that information if they want to contact you, I assume that's okay with you.
Sure.
And again, 100% thank you for that. We're going to get to our last speaker, who is Dr. Mira Pernicone, and she is on the medical staff at Tampa General Hospital as an assistant professor of surgery at the University of South Florida, the Morsani College of Medicine's breast health program. She's taught students at the Mayo Medical School and Graduate School, as well as spoke at various conferences, workshops, and courses on a variety of breast-related topics, including male breast cancer, image-guided intervention, and breast ultrasound. Dr. Pernicone has a particular interest in using acupuncture and Eastern medicine as complements to her surgical oncology practice, which often help to further relieve patient suffering. Dr. Pernicone. You have to unmute Dr. Pernicone. There you go.
Okay.
Thank you. Perfect.
I'm the dinosaur in the group.
Nah,
No,
you're great.
I really just I'm no good with computers, so I can give you a PowerPoint, but I can't give you a PowerPoint in a virtual, whatever this is called.
You're great.
Okay. That was such an excellent and wise counsel from Ms. Ballard on all counts. I cannot tell you how much I appreciated everything that she said, from take 2 steps back and do your planning, gather your information. What excellent counsel this was. All of the talks have been so helpful to patients. I wish I could put my patients in contact with you. At least 300,000 women in the US are going to be diagnosed with breast cancer in 2020. As we have heard from the other speakers, 1 in 8 women are going to be diagnosed with breast cancer. 3.5 million women living in the United States as of January 2020 have or have had breast cancer. And Jewish women have a higher rate of breast cancer because Jewish women have a higher incidence of BRCA mutations, as we heard from our genetic counselor and from Sharsheret. About 2.5 women of Ashkenazi Jews, men and women, 1 in 40 carry the BRCA mutation, which carries a 10 times, it is a 10 times higher rate than in the general population, which carries the BRCA mutation in about 1 out of 400 people. So 1 in 40 people who are of Ashkenazi heritage may carry the BRCA mutation, making Jewish families significantly more susceptible to hereditary breast cancer due to that gene, but also an additional set of genetic mutations are responsible for elevating our breast cancer risk as well. I'm not going to go through the details on those because it was so eloquently presented before. But overall, 14.1% of Ashkenazi Jewish patients with breast cancer in one study, the New York Breast Cancer Study, carried a germline mutation responsible for their disease. 11% in BRCA1 or BRCA2 mutations, and then 3.1% in another mutation called CHEK2. But there are others as well, but that was so beautifully covered. I did not know what the other presenters were going to be covering, so I kind of made my talk as a lead-in to some of the things we can do to help lessen our breast cancer risk. First of all, if a lady has a first-degree relative, that is a mother, a sister, a daughter, who has or has had breast cancer, her own risk doubles from about 12% to about 20 to 24% just on the basis of heredity. Whereas it must be considered also that only 15% of women who are diagnosed with breast cancer have a family history of breast cancer. It is important that you try to maintain a healthy body weight because being overweight carries an elevated breast cancer risk. It's also been alluded to that hormone replacement therapy elevates breast cancer risk, but that's not entirely just, we need to break that down. The best evidence for analyzing the benefits and risks of hormone replacement therapy are gleaned from the Women's Health Initiative, a large study with over 27,000 postmenopausal women. This was a multi-center study, and their results were published in July of 2002 that showed that the risks of combined hormone replacement therapy with estrogen plus progesterone outweighed the benefits that are gleaned from hormone replacement therapy. And these risks included an increased risk, not just in breast cancer, but heart disease, stroke, and having blood clot complications. But not only does combined hormone replacement therapy increase the risk of developing breast cancer, but it increases the likelihood that the cancer is discovered at a later stage, because the hormonal influences on the breast may complicate mammography in the detection of earlier breast cancers. If, however, you've undergone hysterectomy, that is removal of the uterus, then estrogen alone can be given. That is, estrogen hormone replacement therapy can be given to counteract the postmenopausal symptoms. And a study published in March 20, it was actually an additional part of the Women's Health Initiative study in March 2004, concluded that those women who take estrogen alone, that is not the combination hormone replacement therapy, but just estrogen alone, that does not increase the risk of breast cancer or heart disease. However, it may increase, it still is associated with a risk of blood clots. So if you've had a history of deep venous thrombosis or pulmonary embolism, then estrogen hormone replacement therapy would be contraindicated. But if, for instance, one of our BRCA1 or BRCA2 patients who also may consider hysterectomy and oophorectomy, that is removal of the uterus, the tubes, and the ovaries at a younger age, she may benefit, she will benefit, because if you throw somebody into surgical menopause when they're 30, it is not contraindicated for them to receive estrogen hormone replacement therapy. Many of those women do opt to undergo prophylactic mastectomy, which is, if they undergo prophylactic mastectomy with or without reconstruction, plus the hysterectomy, then they can easily and safely be put on estrogen hormone replacement therapy to offer the benefits and the countering of their postmenopausal symptoms. The risk carried with the formulation of birth control pills and the presence of other risk factors like dietary habits and being overweight, high-dose estrogen birth control pills more than double the risk of breast cancer. Also with specific combination types of birth control pills, well, I'm not going to get into the names, but certain birth control pills would be associated and elevate a person's breast cancer risk significantly. So it's going to be important that women who are at elevated risk of breast cancer from any cause, genetic, hereditary, they need to discuss with their doctor if they are going to take birth control pills, what is safe and what is going to elevate the risk, and obviously avoid those. Another changeable item that we can do to reduce our breast cancer risk is to make sure that serum vitamin D levels are good. We are sorely vitamin D depleted. We spend a lot of times indoors instead of outdoors, where the sunshine is responsible for forming vitamin D from sun exposure to our skin. And so we tend to have lower vitamin D levels. And in a 2018 multi-center study pooling data from the University of California, San Diego, in collaboration with Creighton University, the Medical University of South Carolina, and Grassroots Health Initiative, researchers determined that women with the serum concentration of 25 hydroxy vitamin D concentrations of greater than or equal to 60 had an 80% lower risk of breast cancer, 80% lower risk of breast cancer than women with concentrations of less than 20. The units on that are nanograms per milliliters, but I don't think you're interested in anything beyond the numbers. So if your serum vitamin D level is over 60 or equal to 60, you have an 80% lower risk of breast cancer than if your number is less than 20. So it behooves you to discuss your vitamin D supplementation, to have your physician check where your level is and then put you on proper supplementation. And that is all over the map. I would recommend that ladies in general take a minimum of 2,000 units of vitamin D per day, at least until you can have your level assessed by your physician and have your physician make recommendations based on those levels. Another changeable factor that we can do to lower our breast cancer risk is to eat healthfully. Whereas outside the United States, lower fat diets have proven to lower breast cancer risk. Repeated studies from several different reputable institutions have reported that in the United States, low-fat diets are not associated with a lower risk, although a lower fat diet is in general a better idea from the standpoint of heart disease and just your general health and other cancer risks. It is also, eating healthfully would include at least 5 fresh fruits or vegetable servings per day. And some fruits and vegetables are better and have higher antioxidant or protective benefits than others. Broccoli, blueberries, things like that. You should, okay. Current studies, and I've got to say this, current studies say that soy intake, that is phytoestrogens, isoflavones, plant-derived estrogens, all those are all the same concern. They are in higher concentration in soy, flaxseed, edamame. However, the winds change. Right now, the current studies say that there's no elevated risk in breast cancer if you have a high soy diet. Older studies say that there is. I think with all of the non-soy alternatives for dairy-free dietary content, like almond milk, rice milk, cashew milk, all of these non-soy, these have lower phytoestrogens. And flaxseed, that's high in the phytoestrogens. And so with all of the non-soy derivatives or lower isoflavone content foods, it is best to probably, it's okay to have some soy in your diet, but let's not make it the mainstay. If you're vegetarian, or if you, like we do, keep kosher, then you want to have non-dairy alternatives to prepare your food with. That's fine. There are plenty that don't have any soy. So it's okay to use it, but let's have it in moderation. One of the major things that we can do is to reduce or eliminate alcohol consumption in our diet. Alcohol is thought to damage DNA, and that was beautifully brought out in a previous talk. Alcohol may damage DNA, our genetic material, and it also may elevate our estrogen levels. It may cause weight gain because alcohol is kind of wasted calories, and with weight gain, that does elevate our breast cancer risk. So there are several ways in which alcohol consumption can elevate our breast cancer risk. Even what some people call moderate alcohol consumption, 2 1/3 beers per day, 2 1/2 glasses of wine per day, or 2 to 4 shots of liquor per day may have upwards of a 41% increased risk of breast cancer. So the current recommendations are to eliminate ethanol, that is grain alcohol, because it seems more contributory in elevating breast cancer risk. We should limit our alcohol intake to 1 glass of wine per day or less. Whew. I was delighted to read this, as our Kiddush wine is #1 within guidelines for Oneg Shabbat. It's within guidelines of the American Heart Association for reducing our risk of ischemic heart disease, and it's within the current guidelines for not elevating our breast cancer risk. So we'll just consider the Pesach Seder our one-off a year when we have 4 glasses in the one night. That is certainly different from all other nights. Come on, you're singing, right? Ma nishtanaha la ilaha. No, okay. Another thing that we should do is never smoke or immediately quit smoking. That's not just for breast cancer. In fact, the association is kind of an indirect one for breast cancer, but smoking elevates so many other cancers as well. Lung cancer, laryngeal cancer, oral cancer, esophageal cancer, bladder cancer, and the list goes on. So don't smoke or quit immediately. Regular exercise can also reduce our breast cancer risk. It's also good for our mental health. We are outside. We're getting sun to hit the top of our head. It's a great antidepressant. Going to the gym, if you go to a gym or have an exercise program at home, it's good. It does reduce your breast cancer. Careful cancer screening is not just for breast and ovarian cancer. That is, when someone bears a BRCA mutation, as has been alluded to, we should also include other screening programs like pancreatic cancer surveillance with pancreatic MRI or endoscopic ultrasounds of the pancreas, as well as annual dermatology surveillance because of an elevated melanoma risk potentially with certain mutations. We have addressed risk-reducing surgeries. That was excellent. A younger patient with a high breast cancer risk may elect to undergo breast-reducing surgeries. The greater she receives actually a greater potential when she chooses that risk-reducing surgery at a younger age. Again, that does not mean to rush right into surgery. It means to sit back, as was eloquently pointed out, gather information and make decisions appropriately. Older women have more of a risk from other significant diseases like heart disease. And so them undergoing a mastectomy risk may eliminate their breast cancer risk for the most part, but they have other things, heart disease and other systems that may come into play. The prophylactic mastectomies with or without reconstruction involves removal of the breast, a portion of the skin that often includes the nipple and areola, because these are like the tip of an iceberg. They do include underlying, the skin of the nipple and areolar complex contains ductal tissue. So potentially that could serve as a nidus for developing a breast cancer in the future. But now we have developed the technology and techniques for performing nipple sparing mastectomies, which means you get to preserve the natural appearance of your breasts. This is best accomplished though when you have a smaller breast or a medium-sized breast, because if you try to do a nipple sparing mastectomy in a patient who has a larger breast, and now think about it, with a larger breast, even at a younger age, there's more ptosis or natural droop of the breast. So if you remove that breast and you put in an implant or the native tissue to rebuild that breast, potentially that's going to put the nipple in the wrong place. Okay, so that becomes a technical challenge. Can it be done? Yes, it can. It just, there is a slightly increased risk of loss of that nipple from a lack of a blood supply, but it can be done. It's just we can also reconstruct the nipple areolar complex if needed, and then tattoo coloration. It's not your native nipple, but it does serve the purpose, and it does look quite good. And if you opt for the nipple sparing mastectomy, and you're one of the unfortunate ladies who develops, about 20 to 25% of ladies develop necrosis or loss of that nipple because of the blood supply issues to the nipple, please take heart. That can be dealt with reconstruction of a nipple areolar complex and then tattooing of that reconstructed nipple areolar complex. So all hope is not lost if the nipple is lost. If a woman has a BRCA mutation, she may reduce her breast cancer risk by 50% if she chooses to have the ovaries and fallopian tubes removed before she approaches menopause. That is, if she chooses to undergo oophorectomy before she's gone through natural menopause. This will reduce her risk of breast cancer. Obviously, it eliminates her risk of ovarian cancer if it arises. It keeps, obviously, ovarian cancer from arising in the tube and ovary complex at any age. So if you're 60 years old and you have your ovaries removed, it does eliminate your ovarian cancer risk. But in a 60-year-old lady who is postmenopausal, that does nothing to reduce her breast cancer risk. Just wanted to point that out. The careful screening for breast cancer has also been addressed. Early detection, as was pointed out in the very first talk, early detection remains our best chance to beat breast cancer. And so it is very, very important to employ the recommendations of your physician. Generally, we recommend annual mammography beginning at age 40. Obviously, we move that up if you have a family history of breast cancer and your mother or your first degree relative had breast cancer at a very young age, before age 40, then we back that up 10 years. Or premenopausal breast cancer and she happened to be 42 or 45, we're going to move that up and start the annual schedule for her daughters and move it up for her sisters to age 35 if it was 45 at diagnosis. We would also, in ladies who have dense breasts, combine their screening schedule with their annual mammography with bilateral whole breast survey ultrasound, alternating every 6 months with an annual bilateral MRI. So that way, every 6 months, they have breast imaging that very carefully surveys both breasts. We also combine that with an annual clinical exam by your physician, either your primary care physician, your gynecologist, or by your breast surgeon if you're followed by a breast surgeon.
I think we need to start. I appreciate everything. I think we need to start. It was amazing information, amazing. I just know some people had to get off, so I don't want to lose. There were some questions that maybe you can help answer. Sarah, could you help me go through the questions that have come up? And
sure.
And that was amazing. In fact, I ran and got my vitamin D because my doctor had prescribed it, and she never talked about any link about breast cancer though. She just said my vitamin D was low. I went and grabbed it. I'm going to make sure to
Oh,
take it.
yes, take it
So that
seriously.
was amazing.
That's
and all
an
the
easy
other
fix,
information.
right?
Right.
We can't do much about the genes.
No, that was great. I had never heard that. So that was certainly new information. Sarah, can you do a couple of questions?
So one of the questions, someone actually posted on Facebook. They wanted to know, this is a genetic question. If the mother got tested negative for BRCA, does the daughter need to get tested?
Sorry.
Ms. Goldberg?
Yep, just unmuting myself. So if the mother was found to have BRCA testing and was found to be negative, but there's still a family history, we would just want to make sure that there were other genes that were also screened for as well, aside from just those two. The other thing is that, as I had said, this was a little while ago, if somebody tests negative on one side of the family, we want to take into account that paternal family history as well. So if there's a family history or there's concern about the other side, then they may still consider testing for themselves.
Thank you. Another question, I guess, Dr. Pernicone, you talked about birth control. Are there certain types of birth control that are considered lower risk in terms of increased risk?
Yes, I think you can use a diaphragm, condoms, non-hormonal, or you can go on what is considered a low dose estrogen combination therapy, where it is really the things of concern are certain types of estrogen and then higher dose estrogen. But for the most part, the lower dose estrogen within the birth control pills is thought to be safe.
Okay. There's another, oh, sorry.
Oh, no, just one more thing. Concerning the abortions not elevating your breast cancer risk, that's been removed from the literature. But in 1995, a study did show, a reputable study did show that not just elective abortions, but miscarriages or spontaneous abortions did contribute to an elevated breast cancer risk. Now, that's not said to place guilt or anything else. What it said is so you'll be armed with that information to consider that a risk factor, because, for instance, when we take a history to try and determine, to calculate a breast cancer risk of a lady, so we can say who is 20% or higher, what is your breast cancer risk, who do we need to put into the high risk screening schedule of greater than 20% risk, lifetime risk. Well, we need to know, did you have any preterm, we need to know at what age did you have your first baby, and have we had any miscarriages? Certain tools use this as an assessment tool. That is not to place guilt, but rather so you'll be armed with the information that you may have an elevated risk, and to take your breast cancer screening seriously, because it is imperative that we kind of be of the mindset we have to know this information so that we can detect breast cancer as early as possible. That's the end of it. We just want to detect it as early as possible so that we can avoid perhaps the need for chemotherapy. The other thing I wanted to say was, once you are diagnosed with breast cancer, we now have molecular panels that we can run on a breast cancer that look more than just the receptor status and the HER2/neu status. We have entire profiles, MammaPrint, and other risk assessment tools that we use to look at a tumor to say, does this lady need chemotherapy? Would she benefit from radiation or not? More than just tumor size and estrogen receptor status, HER2/neu status, progesterone receptor status, proliferation index, how fast is it growing, things like that. We have a whole panel. So we have a lot of tools to help decide how to manage breast cancer. But one thing you can do to lessen the likelihood that you're going to need chemotherapy is to find it early before you'll need any chemotherapy.
Thank you. Sarah, any others?
Yeah, someone wrote, I had a hysterectomy at 40, but kept my ovaries. Don't seem to have any signs of menopause symptoms like hot, cold flashes other than stopped menstruating. Never took any hormones. Is that okay? How do I get the serum check? I have been on vitamin D per doctor for 5 years now.
Well, that's a lot of questions. Okay, first of all, if you're not having postmenopausal symptoms,
don't.
Mazal tov. That's great, because you really don't need to have estrogen on that basis. Okay, if you've had your uterus and your ovaries removed, did I understand that correctly?
Said she had a hysterectomy.
Yeah.
Okay. Oh, so they left the ovaries in place.
Yes.
Okay. Is there a family history of ovarian or breast
I
cancer?
don't think we know that.
Okay. I'm deferring to Ms. Goldberg. Does she need to be tested?
So that's a good question. So in general, when somebody has a hysterectomy, it's just the uterus. So if her ovaries are still intact, then essentially they're still functioning. They're still releasing hormones. So it would be, she's not at an extra high risk, but it's sort of the same as other women as far as her exposure to hormones. And in terms of genetic testing, if there's any family history of breast or ovarian cancer, or another reason why we think she may be at risk for ovarian cancer, then, certainly she could pursue genetic testing and then help her figure out if there's any increased risk that might suggest further surgery.
Very reasonable.
Thank you.
This one I think probably is for Brianna. I just had one breast mastectomy and have been found to have another type of breast cancer on the other side lymph node. I will have to have a lot of chemo. Is there someone I can talk to or connect with to help me understand what I am in for?
Absolutely. Best way to get in touch with Sharshara is I'll put the 800 number in our chat. But if you can go to our website and type into our live chat, or if you want to speak to someone, give us a call tomorrow morning, and we're happy to put you in touch with a social worker who can connect you with a peer supporter if you want to talk to someone who's been through it. But definitely, absolutely, yes. The answer is yes.
Great. Thank you, Brianna. I think, was that it, Sarah?
Yeah,
Was
I
there
believe
more?
that's it.
Okay. I just want to thank everyone for attending this important and perhaps life-changing program, because there was the most amazing information. I feel like we covered everything, if that's even possible. I would ask you all, if this has been going live on Facebook, if after you get off, you can go on to the Jewish Federation of Greater Orlando. It's on our Facebook page. If you could share it onto your own so that more people can see this. I just think there's, especially being it's October and everyone's thinking about breast cancer this month, please share it, because again, we want to try to get this information out to as many people as possible. Dr. Iyengar and Dr. Pernicone, thank you so much for taking the time to do this. Your information, again, life-changing, amazing, thorough. We really appreciate it. Thank you to Brianna from Sharsheret, Hillary, I believe you're out there somewhere, Hillary, and Emily from JScreen, Deborah from Susan G. Komen. You were all amazing and so helpful to the community. Randy, thank you so much for sharing your story with all of us. It was so important to hear that and inspiring to all of us. Sarah Florence, if you're still on, thank you for your beautiful music. And Sarah Gittleson, thank you for all your help helping me put this together. We encourage everyone to step up and begin to advocate for yourselves. It can make all the difference in the world. Please utilize all the resources we have shared with you. And above all, make sure you get your mammograms. Again, we will put all the resources on the Federation web page and Facebook page tomorrow. So if you need anything, it will be there. Please feel free to reach out to me at Federation. I can get you any information you need. I talk to most of these ladies quite often. We can get you in touch. And a big thanks to everyone. Appreciate it. And have a great rest of your day.
Thank
You too.
you.
Thank you.
Thank you. Bye-bye.